Welcome back to Endo Bites, the podcast where we make practical endocrine topics into a 15-minute learning moments. This is tailored for primary care providers, advanced practice providers, students, and all learners who would like to know more about practical endocrinology. I'm your host, Vidya Kidambi, professor of medicine and chief of the Division of Endocrinology and Molecular Medicine at the Medical College of Wisconsin in Milwaukee. Today, we are diving into nutrient that's everywhere in the media, in our patient stores, vitamin D. And it's extremely important, but there are a lot of questions about who should take it, who's truly deficient, and can there be too much of vitamin D? To answer all these questions, I am joined by my colleague, Dr. Joseph Shaker, who is a professor of medicine at the Medical College of Wisconsin, and he is a national expert in metabolic bone diseases. Dr. Shaker has a gift of cutting through all the confusion and bringing clarity, whether to his patients or colleagues. We all rely on his expertise, everything bone. So, Dr. Shaker, thank you for being here.
Thank you, Vidya. I'm really glad to be part of this series. This is a topic that comes up every day in my practice and others, and I'll try to help unpack it.
Yeah, that's fantastic. So we're going to first start with the first question. Again, as you know, we always start with basics. So how does vitamin D regulate bone health and metabolism?
So I think it's really important to understand basic vitamin D physiology. Vitamin D is either made in the skin under the influence of UV light, and that's cholecalciferol or vitamin D3, or it's consumed in food or supplements as cholecalciferol or ergocalciferol, the latter being plant vitamin D or D2. Vitamin D is then 25 hydroxylated at the liver in a largely unregulated step to 25 hydroxy vitamin D2 or D3, and subsequently activated in the kidney to 1,25 dihydroxy vitamin D2 or D3. This step is very highly regulated and stimulated by parathyroid hormone. The most important action of 125D is to increase absorption of calcium and phosphate in the gut. And these minerals are needed to adequately mineralize the skeleton. So if you don't have this, in children you get rickets, and adults you can get osteomalacia.
Okay. So what are the common, you mentioned sun is one of the main things, but are there any dietary sources of vitamin D, or is it mostly need to be obtained as supplement? How does it?
So many things are supplemented with D. Milk, for example, has D in it.
Like orange.
Bread is sometimes supplemented with D.
Okay.
And we make it through UV exposure.
Okay. Yeah. So who would get deficient? So what are the most common causes of vitamin D deficiency?
In some populations that cover a large part of their skin and don't live in a very sunny place, you can get vitamin D deficiency. But in the United States, the most common causes are things like gastrointestinal disease, like short gut, inflammatory bowel disease, celiac disease, or gastrectomy, or more commonly now, bariatric surgery. Yeah. It's particularly important to recognize that celiac disease can be completely asymptomatic. Anticonvulsants, particularly the older ones, such as phenobarbital and phenytoin, alter vitamin D metabolism and can cause vitamin D deficiency. And lastly, obese patients tend to have lower vitamin D levels.
Okay. So you mentioned about, northern climates or, where there's less sun exposure. We don't often have, recommendations to treat patients in northern climates differently, right? So is that something that should be considered, whether to measurements, or is there, so?
I don't think routine measurement is necessary. We do have RDA guidelines based on age and whether or not a woman is pregnant that are reasonable supplements that would make most people replete. So routine measurement, I don't think is recommended.
So that really comes to my next question, is that who should we measure vitamin D, and how do we measure vitamin D? And often the confusion is whether to, we 125, 25, what should be measured?
So first of all, I think the patients it should be measured in are people with bone disease, for
Okay.
example, osteoporosis, people who have diseases or medications that could cause vitamin D insufficiency, for example, GI disease, anticonvulsant therapy, and so forth. The measurement is a source of confusion. So the best way to assess vitamin D stores is to measure 25-hydroxyvitamin D. Measuring the active metabolite 125D is not useful in assessing vitamin D stores. And that's because 125D is present in 1,000-fold lower concentrations. And as you become vitamin D deficient, parathyroid hormone goes up, will stimulate the conversion to 125D, and you can maintain normal 125D levels even if you're vitamin D insufficient or deficient. Conversely, if you infuse someone with calcium and make them hypercalcemic, that will suppress PTH, decrease production of 125D, and that 125D will be low despite the fact that they're vitamin D sufficient. The measurement of 125D is useful in the evaluation of PTH independent hypercalcemia, hyperphosphatemic, and hypophosphatemic disorders, and sometimes in CKD, but shouldn't be routinely used for assessing vitamin D stores. Now, there's controversy about what the level should be. Levels probably greater than 12.5 to 15 nanograms per mil will prevent osteomalacia. But there's more controversy about what levels required to prevent an elevation in PTH that would cause bone loss. And that's probably somewhere between 20 and 30 nanograms per mil. The Bone Health and Osteoporosis Foundation, formerly known as the National Osteoporosis Foundation, recommends that in patients with osteoporosis, we maintain a level between 30 and 50 nanograms per mil.
Okay. Yeah. So, I think in our system, there were so many people getting confused between 25D measurement and 125D measurement. In fact, our organization has removed 125 forever. And then they actually replaced it with calcitriol because of mistakes. So remember, folks, you have to measure 25-hydroxyvitamin D and not 125D when you're suspecting that there may be problems with the vitamin D levels. So, yeah.
Could I make another comment about the measurement? So Neil Binkley and his colleagues from Madison have shown that the routine 25D immune assay may underestimate the 25D level when ergocalciferol or vitamin D2 is being used. Furthermore, there's this issue of intermittent high doses of vitamin D stimulating 24-hydroxylase, which inactivates vitamin D. For this reason, we advise against the use of intermittent high doses of D2 and prefer a daily dose of D3 adequate to achieve your goal level. If you are going to use D2, you have to measure the D by HPLC TMS, which at least in our place is a more expensive test and a send out. The other thing I want to mention is the issue about biotin. So biotin, which is in hair and nail products, if in high doses, can interfere with many assays, and it can cause artifactually low big molecules like TSH, PTH, and troponin, and artificially high small molecules like free T4 and 25D.
Okay.
So it's important. We tell people to be off them for a week or so before they get their blood tests.
So I think we kind of touched a little bit on that vitamin D supplementation. So what you're recommending, it was, a lot of my patients from, people who got those 50,000 units once a week, they still come and ask me for that. So what you're recommending is that if someone is vitamin D deficient, now the recommended management is over-the-counter 1,000 units or 2,000 or 5,000 daily supplementation rather than this big 50,000 unit vitamin D supplementation.
So in my practice, and you can get 50,000 D3 if you want to, which alleviates the assay problem. I have a few patients remaining on it because they can't afford over the counter and because Title 19 or Medicaid won't cover the 50,000 D3.
Okay.
And so that in those patients, though, when I measure it, I do the send out HPLC TMS.
So maybe I want to be a little bit more, we kind of talked about it in a roundabout way, but for the clarity, so can you explain again D2, D3, and what's the preferred form? Which one is animal, which one is plant? So our listeners can.
D3 is animal. It's what we make in the skin or you take in most daily supplements. D2 is plant. It's what's often used in the high dose ergocalciferol. That's
Okay.
what ergocalciferol is, plant vitamin D. And there is some assay issues in many of the immune assays to underestimate it.
So the preferred is D3, whichever, whether it's lower amounts or some specific patients, higher amounts, because that's what is well measured in most common assays. So that's great. So I think that's where a lot of confusion is as well. And one couple of other questions. So one is, can vitamin D toxicity occur, and what situations, and what does it do for us?
Great question. So classic vitamin D deficiency occurs with 25 hydroxy D levels greater than 200. And this can cause hypercalcemia, hypercalciuria, kidney failure, and even death. Several years ago, there was a case in New York City with a supplement that had tons of vitamin D in it, where people had severe hypercalcemia, and I think some people even died. But that said, there's a different form of vitamin D toxicity. Dr. Burt and her colleagues from Calgary gave randomized people to 400, 4,000, or 10,000 units of D daily. And in postmenopausal women in the higher doses, which achieved levels of closer to 80 nanograms per mil, they found the volumetric radial bone density actually decreased. So too much vitamin D is probably bad for the skeleton.
Okay.
And so I think we need to think of vitamin D like every other nutrient. There's a sweet zone. There's no nutrient that I know of that you can't have too little or too much.
Yeah, so I think too much is not good. I think maybe it's a right point to talk about, there were always these extra benefits other than skeleton were always proposed for vitamin D. What do you think about that? Is there any truth to those? That's the reason why lots of people take it.
So the extraskeletal benefits are obviously very controversial. The VITAL study showed that supplementation of vitamin D, 2,000 units daily, in a population that already had a mean level of 32 nanograms per mil, didn't really provide much additional benefit. The problem is that they're vitamin D replete. I don't know what the answer would be if they were vitamin D deficient.
Okay.
I would say most of the studies where they've been randomized don't show that giving higher and higher doses of vitamin D helps much. There's also this question about reverse causality. So with COVID-19, there was a lot of data that suggested that people that were acutely sick with COVID-19 and that had lower vitamin D levels did worse. And that may have been because sicker people start off with lower vitamin D levels, not because the vitamin D helped them. And what happened is we had lots of people taking lots of vitamin D, not recognizing there was potential toxicity for it.
So one other question. So often, maybe as a specialist, so we have vitamin D, we check parathyroid hormone, look at calcium and phosphorus as kind of in that, zone of whether, vitamin D deficiency. Is there any other things that, severe vitamin D deficiency can cause osteomalacia. So, let's say for our common practice, what are the other things they should be looking at when they see vitamin D deficiency? Is it calcium, phosphorus, alkaline phosphatase? Do you have any, or is that only?
For most of the patients we see with, modest insufficiency, there probably isn't much else we have to do. But if you see a patient who's severely deficient and they have a high alk phos, for example, like you mentioned, and secondary hyperpara, you need to really think about, could they have osteomalacia? At this point, I might make that assumption if they had all that scenario, that osteomalacia is possible. If they have a 25D of 5, they've had severe GI disease, they have a high PTH and a high alk phos, and I would treat them as if they did with calcium and vitamin D. And of course, wouldn't use an osteoporosis drug first. You want to correct that.
Yeah, so we'll probably discuss that a little bit more, why that is important to identify if someone has severe osteomalacia, that means severe vitamin D deficiency with other metabolic consequences. So we'll talk about that more in our upcoming episodes. Thank you for listening to the episode. Joe, this is fantastic. So we're going to wrap up this episode of Endo Bites, and I hope this conversation helps you better understand clinical relevance of vitamin D and how you can treat your patients better. And if you found this podcast helpful, please subscribe, share, and help us spread the word with others who may be interested in managing endocrine conditions. Now, in our next episode, we shift our focus to osteoporosis. So we'll have a few episodes where we will talk about how to screen, diagnose, and treat osteoporosis. Thank you.
Thanks, Vidya.